Well, good morning, everybody. I'm Mark Schwartz. I'm the director of Harmony Place in Monterey, California. And I've been working in this field most of my career. I started in the late 1970s with John Money, then with Masters and Johnson, and then have had a number of our own treatment centers. And this first slide was a Larka 1991, and I want to begin with some reflections of why I picked this topic, which is sexual compulsion, alternative treatment. I feel like what I do now is radically different than what I did in the 70s, the 80s, and the 90s. And as I read the books on treatment of sexual addiction and sexual compulsivity, I find that what I'm doing really is divergent from what's written in the books. I find a lot of that necessary, but not sufficient. And hopefully by the end of the talk, you'll see what I mean. I had a client yesterday who said to me that if they had to give up pornography, they'd rather die. And I reflected upon that most of the evening. And I realized that I don't really quite get it. And I struggle to really get it. What is the client saying to me? I'd rather do pornography than die. He also says that when he has sex with his wife, he thinks to himself, well, this is going to interfere with my doing pornography later, so I'd rather do the pornography. Why would somebody rather do pornography than have sex with a partner? Now ponder that for a minute, and I wonder what that means. But I think that maybe I don't understand how alone he feels inside, and that maybe pornography is his only way of feeling any joy or pleasure. He says it's a dopamine release. It's an addiction. And the thing about addiction is it doesn't make any goddamn sense why a person does what they do. The cost is much greater than the benefit to an outsider. But maybe because we don't really understand the disconnection and the aloneness. They say that addictions are baffling, powerful, and cunning. And I certainly think that's true. I think that the cunning part of it has always been a mystery to me. That how it is that a person somehow that in their mind is finding that the substance or the action is the way of living. I had this a lot when I used to treat eating disorder every day. And the person would somehow require the anorexia or the bulimia in order to survive. It sort of was their source of strength. It was somehow the reason to be alive. And giving it up seemed like they were giving up everything. So I struggle really to understand that in some ways. And it's an addiction. It's also an intimacy disorder. An inability to use people as a resource. So even if you have people who love you, you're not able to accept their love. There's something blocking it. And so for much of the career, I think I decided that it was primarily an intimacy disorder. And that as we studied attachment wounds, what we saw was that there are people who are starving for love and attention and caring, and yet are avoidant at the same time. And so when you're feeling both hunger for and fear of, maybe pornography or going out with prostitutes or call girls or some other mechanism allows you to be both close and distant at the same time. Maybe it's a perfect storm. It's a perfect solution in some ways to that AC pattern of attachment. Now, what I'm going to say today is that all those explanations certainly have been true, and this idea that a compulsion covers up this interior emptiness is true. But I think the message I'd like to deliver today is that maybe the most useful thing that I've discovered in my career was the nature of dissociation. What is dissociation? Dissociation is somehow where you've survived by not connecting, and that the solution of dissociation is that person is somehow trying to solve the puzzle of how you can be part of and yet separate at the same time. And so there are things that happen to you as a child, and if you associate those things and assimilate them into your consciousness, it just becomes too scary to be alive. And so your brain has this wonderful mechanism of keeping somebody distant and at the same time as present. And so dissociation kind of keeps information from coming in that would be too great for you to be able to know, and allows you to be able to keep information out. Now think about it for a minute. Why would a person be primarily aroused by somebody tying them up or whipping them? Why do they need dress in women's clothes in order to be able to get aroused? Why would they need leather in order to find themselves aroused? Any of the paraphilias, any of the alternative kinds of things, they must come in a way of twisting and turning. So you can just think of people's arousal levels being tied into the imagery. And so what is it that happens? Well, a person feels a sense of depersonalization. That is, they feel that they don't feel like they can connect to other people. They feel a sense of apathy. They feel a sense of emptiness. And they'll do anything to escape that emptiness. And so the sexual addiction comes in order to be able to solve that riddle in some ways. So what I want to be talking about today is that somehow there is a problem with affect and emotions. There's a problem with the self system and feeling like you're a person, problem with identity, and that maybe the purpose and the function of a lot of addictions and compulsions have to do with just a form of being able to know things and not know them at the same time. So when I think about a treatment program for sexual addiction and sexual compulsion, what I've had to put together is the combination of a cognitive behavioral approach with a psychodynamic approach. And so I just sort of let's just go through the circle. At a behavioral level, a person needs urge cards, which is, to be able to identify when they feel the urge to use, what are 5 alternative things they can do at that moment. Because your mind just goes blank and you go from stimulus to response automatically, and you need to break that up in some way and have alternative coping responses. So, in relapse prevention, what I've always said to people is that it's not the relapse that's the critical thing for me. It's what you've done when you have those feelings. And so, for example, when you have that, could you call somebody? Could you watch a TV program? Could you distract yourself in some ways, like with any addictive behavior? On your computer, do you have blocks? So you're not going to go while you have the stimulus of turning on your computer or going to a website of some sort. So, for example, I have them put Covenant Eyes or Net Nanny on their computer or their phone so that there's something in between. Shame reduction. Oftentimes I have them come to group each week and talk about what happens when they have their urges and the feelings that they feel inside, and to be able to get the affect shame binds and how to be able to reduce them within the group setting, and go to 12-step meetings SA or SLAA, and find out there are other people like them. When they're with their partner, usually there are performance concerns, and the hyposexuality with their regular partner have a lot to do with feeling somehow like the pressure to perform and to compensate. There's trauma work that needs to be done. Usually there's been some history of severe neglect and abuse, and that gets enacted in varieties of sexual addiction. I've talked about the attachment and the intimacy issues, that you're afraid of getting too close, and you don't really feel like when you get close to people that you can connect to them in some ways. 12-step meetings is having a community of people that you can connect to and friends. Social skills, that you can feel alone, isolated, and not have the ability to form close relationships with other people. Dating and courtship, sometimes you feel like you don't have the skills to be able to meet someone and court them in a way that would allow you to form real relationships. Maybe there was early trauma, and you have a variety of avoidance strategies and defenses that keep you from connecting with people and being able to delineate some of those, so you see your own MO, modus operandi. Distorted beliefs about yourself and other people that come from early childhood. Truly having compassion for other people. I think, for example, that when you're having chronic affairs, it probably means that you're not able to realize the pain that you're causing to the people you love. And if you could feel their pain, you probably couldn't do what you do. Emotional regulation, particularly rage and anger, floats into a lot of sexual arousal patterns. And one isn't even aware of the level of rage and anger that they carry with them. And sometimes by looking at pornography at ages at 9, 10, and 11, you have arousal patterns where some sort of tolerance has developed and you need more and more deviant arousal in order to be able to get the same hit of dopamine. So you condition your brain to turn on to atypical kinds of stimulation. And then today, I'm going to be focusing more on dissociation and what to be able to do with that. So you can see the complexity of a treatment plan. And if you undertreat any one of these, you typically are going to find yourself having a high degree of relapse. So today, when I talk about alternative treatment approach, these other areas are more typical and people have focused on them. But today I'm going to focus on the dissociative pattern and what to do with that. Okay, so I think you can all agree with me that there is a component of emotional dysregulation. And, Robert Stoller, who wrote in the 1970s, always said that perversion was the erotic form of hatred. And he said that the person's life is dedicated to reliving the trauma in disguised form. And Stoller's words always come to mind when I'm dealing with sexual addiction, because in so many ways it's a form of rage and anger that gets twisted and turned into eroticism. And how does that happen? How does eroticism become a source of rage and hostility? Well, again, I think I learned a lot about this by working with anorexia and bulimia. Anorexia and bulimia are also forms of perversion. It's a form of rage and anger that the person turns towards themselves. And one of the things we found was that almost always with anorexia and bulimia, there were sexual correlates in the sense of sexual addictions and sexual inhibitions that went with that syndrome. As the eating disorder got better, sexual problems became more clear. And the same thing's true with sexual addiction. As we begin to get that under control, a lot of people find themselves having difficulty around food. And so how is it that these natural functions of food and sexuality become twisted and turned into these perversions? And I think what the top says is that an abused child discovers they get a release from changing their affective state. And so they have a high degree of anhedonia, a numbness, an inability to feel connection. You're living in your own world. You're in a highly dissociated state. And you feel different than the other kids. You feel alone. You feel scared. You feel like you have no secure base and no one you can turn to, and it's going to go on infinitely. And so in that state of dysphoria, you come across something and it gives you a temporary state of release, and it becomes a solution to your dysphoric kind of state. And so how is it that rage fits into that? Well, rage is a way of releasing the anger you feel because of the mistreatment. It's not fair. These things shouldn't be happening. Someone should do something. Help, help. Nobody comes. And so in that state of utter frustration and anger, the solution gets turned into somehow the discovery. I think that the beginning of electronic states, I think, really fits into this. As I reflected upon my own career, that what's happened, I think, in the 90s was the beginning of people turning to electronic states, their computer or some alternative to it, their phones. And particularly during COVID, I think people were left alone in their rooms with their electronics. And in that, they moved into a state of moving from their aloneness to their connection to other people on the computer and became sort of addicted to it. And I think we're all well aware of that. But what came with that was oftentimes the sexual arousal, and the sexual arousal became electronicized also. And so you're more turned on to the image that is coming in your eyes than to touch and people holding you and connecting to you in a physical kind of way. I think we have a whole epidemic of people who are now, when they're getting into committed relationships, they need to create some image inside their mind of electronic that arouses them. And so even when they're with their partner, they're kind of distant and disconnected and having to create the imagery in their mind of what their pornography kind of connected to them in their mind, and utilizing the image rather than the person in order to be able to be sexually aroused. Now, if you buy what I'm saying, then the solution has to be being able to deal with the depersonalization of not feeling human and the depersonalization that comes from not being in your body. So one of the things I'm aware of when I'm working with a client is that one client said, "I don't think I can love." Now, again, that's another one of those profound statements. Well, do you have to teach a person how to love? No, I think it's a natural function. So the question is, what is it that's interfering with that person's capacity to feel love? And the answer to that probably is they don't feel much of anything. When they express a feeling, it's really a thought. They think they're feeling instead of feeling they're feeling. So the person becomes highly intellectualized and cognitively based and in their cerebral cortex. And so they're thinking their feelings, but they're not feeling their feelings. And that's really been true across the board, I think, a lot in psychotherapy. Is so much of psychotherapy is recognizing that people are blocked in their capacity to feel their feelings, and they end up thinking their feelings. And a lot of the cognitive behavioral approaches have played into that, and they get people much better at cognitively being aware, but not allowing them to feel their feelings. So if they think they love somebody, they don't feel they love somebody. And so in many ways, we're seeing that as what we call love addiction. Love addiction is where you think that the solution to all your life's problems is to find someone to love you. And Then you find someone to love you, and it doesn't solve your life problems. And the question is, what is the solution to that? And what we know as psychotherapists is secure attachment with self. So what is secure attachment with self? The ability to be able to self-soothe, the ability to be able to find comfort in oneself, and being able to utilize other people as a resource rather than feeling so all alone. So let's take what I'm saying. And one of the things that you know about addiction is that when you begin an addiction, it kind of grabs you. And you get that dopamine hit, those high highs. And also, there's something interesting that happens, which is that when you start a substance, the natural substances of your body stop. So, for example, if you start doing a sleeping pill, the natural juices of your body that create sleep stop, and you become dependent upon your sleeping pill in order to be able to sleep. And that when you get off that sleeping pill, it takes a while for your natural juices to begin. And, the opponent process theories were always around that whenever you take a substance, you alter the natural homeostasis, and your body fights it in some way by trying to compensate for whatever the chemical is and fight it in some way. And so what happens, like when you fall in love and you break up, is that person was a solution and gave you the dopamine hit. And then you get anhedonia whenever you break up the relationship, and you're in all this pain, but there's no relief from it till the natural state begins again. And so in this opponent process, there's the realization that you can begin to get addicted to pornography, for example, or to going out with call girls, or to whatever it is your paraphilia is. And it becomes a relief because it allows you to have the joy and the pleasure, but then you become dependent upon that, and your natural juices just stop. And so you're not able to experience pleasure and joy. So when the client says to me that if they give up pornography, they're going to die, or that it feels like they're going to die, I think what they're saying in some way is that there is no joy in their life. There is no real pleasure in their life other than their addictive behavior. And what they're saying is that they're not able to receive love from connection with other people. So what do we do that allows people to receive love? Well, that's sort of what we're going to be talking about today. One of the things that I've been able to gather from working with the dissociative state, and here I'm going to rely heavily on Richard Chafetz's book, Intensive Psychotherapy for the Persistent Dissociative Process. If you're going to read one book, I really highly recommend this book. And I'll be taking a lot of what I'm thinking and saying today from that, because he says it probably better than I could, which is that when you have people who have avoidant attachment, oftentimes they'll hyperactivate the sexual system and to deactivate the need for attachment and intimacy. And so where the rest of us may feel a hunger for love, a hunger to be loved, a hunger to give love, a hunger to connect, that natural kind of bonding system that seems to be part of being alive gets dulled for them. And so they use sex as a way of feeling lovable, feeling desired. And you see this a lot in adolescence, where a person is trying to check up the number of people that want to have sex with them as a sign that they're lovable and that you're wanted or desired in some way. And usually adolescence is a time when you discover that it's a quick high, but it doesn't last. So what they used to say about cocaine or crack was that you get this high, and then there's this quick fall. And it's the latency between the high and the fall that makes crack so addictive. Well, sex is sort of like that. You end up having this sexual experience, and you quickly fall from it. And there was a period of time that I would deal with men who will be tricking in the homosexual community. And what they would do is they would have a trick and they would get really high, and then they would quickly fall into depression. And the only way they could get out of that was to have another trick. So what they would do is have 7, 8, 9 tricks in an evening, going back and forth between high and dropping, and go home and be miserable. And so over time, it became highly addictive and necessary, but also undesirable, which is the definition of addiction. And so the idea then is that sex becomes a way of connecting, and the only way of connecting. And so when a partner does come into your life, it doesn't seem to give you the same high as what you did in the addictive substance. Okay, so the idea then is there's an avoidant attachment system, and there's a disconnection from other people, and the person is feeling a lack of self-integration. So the other thing I've noticed among the people that we treat is they'll come in and they'll say something like, I don't really know who I am. I don't know what my life is about. I feel like I'm really oriented to pleasing other people and being what other people expect me to be, but I don't really have any coherent sense of self. And so I thought about that a good bit. And in one of the previous webinars, I talked a little bit about the development of the self system. And we'll say a little bit about that today. But what it reminds me of is that they've never grown up. That what happens around the ages of 18 to 22, something like that, where a person moves from adolescence into young adulthood, is they begin to develop some autonomy and some coherent sense of self and some clarity about what their life is about, and maybe a spiritual base, which is a secure base where they can feel like they can be alone and they can feel like they can be with people. And I would say that one of the key components of working with sex addiction is beginning to see the development of the real self and moving a person from adolescence into adulthood. And so many of the people who with sexual addiction do not have a coherent sense of self, don't have an identity, and they don't know who they are. So you can see that sexual addiction is a symptom, but underneath the symptom is the problem. And the problem is not having an identity, not having a sense of self, not having coherency, and you have to have an I before you have a we. And if you don't know who you are, then you're going to searching for another person to finish you, which we call fusion. And by then finding that other person, you're fused with the other person in a love addiction, and that's both necessary and distressing at the same time. So in order to be able to treat the sexual addiction, one has to be able to have much more coherency about who they are and what their life is about in some ways. And what they do that keeps them separate and alone. And so if they get into a relationship, it usually is problematic because of all the ways that they've created defenses in order to not feel safe. Now let's think about it for a minute. Why did a person develop defenses? Well, as a child, there's that natural bonding, loving and caring. And the person who you're bonding with also hurts you in a variety of ways, abandons you in certain ways. And so what we hear in their histories is, my mom was a crack addict. My mom got married to somebody and abandoned us. My mom hated men, and because I was a boy, I reminded her of the father who rejected her and were cruel and unkind to me. And so there's these extreme cases and where the person that they were trying to bond with was also a person who hurt them in a whole variety of ways. And so what a person has to do, obviously, in order to survive, is they have to internalize that they're defective and they're bad. And if they're defective and they're bad, they deserve to be treated in this way. So they come in with these cognitive distortions where they feel like they're bad, they're defective, they're unlovable. And these beliefs are frozen into their brain and in the deep structures, in the affective system. And so they're not really beliefs, they're actually affects, shame affects. I'm a defective human being. And if you try to go in it cognitively and say what you were told wasn't true, they're lies, it doesn't really take because they're heavily in the affective structures. So how does one change a shame affect structure? And I think a lot of our psychotherapies these days are really oriented towards that goal. Whether you're doing EMDR, or whether you're doing affect accelerated psychotherapy, AEDP, or if you're doing internal family systems, or if you're doing Gestalt or somatic kinds of therapies, I think all of them have the idea that the key change agent in psychotherapy is the relationship between the therapist and the client. And what the client is going to do is, as the therapist attempts to be able to attune themselves and connect and show compassion and kindness and loving and become a secure base, the client is going to defend against that with a whole variety of defenses to block that, because what they've discovered is that that connection is dangerous. And if you allow yourself to need and have needs, you're going to get hurt in some way. And so dealing with that relationship in the psychotherapy is an absolutely essential agent in order to neutralize some of those shame binds and help the person begin to recognize the affect of feeling defective and bad in some core kind of way, which then keeps them separate and dehumanized, depersonalized, and disconnected in some ways. Now, this is all stuff that we know. It's what they used to call at Menninger good old psychotherapy. And good old psychotherapy is where assuming that the therapist has the capacity to form genuine connections. And so one of the things that maybe is missing in a lot of therapist training is the capacity to form really connected relationships with people, so that when the client comes in and defends, and let's say gets really, really angry at the therapist, that the therapist doesn't react to that and quickly say, oh, that client is borderline, or that client is too damaged in order to receive. But to understand that that defense is a natural reaction to you attempting to be able to connect and be able to say, it's perfectly safe in this room for you to get angry. It's perfectly safe in this room for you to numb out. It's perfectly safe in this room for you to disconnect. And I am going to be here nonetheless and become, a secure base with unconditional caring. And that connection, if it's persistent over time, will eventually allow some of those defenses to be let down and the person to begin to see themselves as lovable and care and have a secure base, which they then can translate into the real world. Now, one of the great defenses then is dissociation. And dissociation means that you automatically numb out. Now, dissociation, I think, it has lots of different meanings to different therapists. For some people, dissociation is a numbing out. For some people, dissociation is just not being there. Some of the people I treat with sexual addiction, they get absorbed into distractions. And so typically what goes with it is comorbidity of attention deficit disorder, sometimes bipolar disorder, which includes in it obsessive compulsiveness. And so obsessive compulsive, attention deficit disorder, all those are absorption disorders where they get distracted by their OCD. They get distracted by their absorption. And so they start something and they get absorbed in it and it steals their attention in some ways. With bipolar disorder, they'll start 3 or 4 different tasks, but they don't finish them. They make commitments to be somewhere, but then they cancel them. And so that's one form of dissociation. Another form of dissociation is the depersonalization, where you feel you're alone and separate from people, even in a crowd, and don't know why, but you just don't have the ability to be able to be with. A third form of dissociation is where you have amnesias, where you forget things, where you know things but don't know them. And so with dissociative identity disorder, you have people who buy clothes and they don't remember buying them. When I first started dealing with dissociation, I brought a videotape machine into my sessions. At the end of the session, I would give the client the videotape and have them take it home, because I thought there was so much that happened during the session that if they observed it, they would then be able to get much more out of it. And to my surprise, what they would do is they would dissociate during the therapy session and not remember anything we discussed. It was incredibly good. I would think the better the surgery, the more the dissociation. And then they would watch the videotape and they would dissociate from the videotape. And so it was no solution to be able to give the videotape. The other aspect of dissociation is breaking into different self states. And so that's what this picture denotes, is that somehow there's separate self states. And when there are different self states, the part that's doing the acting out is not the part that's in the office. So you'd be doing great psychotherapy with Joe, but the part that was acting out was not Joe. It was a self state that was, sort of having their hands over their ears and not listening and not hearing. And so early on, when working with dissociative disorders, I realized that there has to be a way of accessing the self state that's acting out. And usually it was more than one. So for example, with eating disorder, there'd be the anorexic self. The anorexic selves was the key, that there were several self states, maybe a 5-year-old or 7-year-old, and one had to access those self states in order to be able to help the person. So one of the premises of this talk is that oftentimes therapists are doing therapy with the wrong part, and accessing the parts that are doing the acting out are really critical. So one of the things I started to do many, many years ago was the person that was doing the acting out, let's say it was the anorexic part, I would then see if there was some way that I could access the anorexic part and bring that part into the session. And many times it was a young part. And so what one had to do is be trained in child and adolescent psychotherapy in order to work with adults, because it's the child and the adolescent that was doing a lot of the acting out. And so you had to attune yourself to the self state that was being acted out in a variety of ways. And some of those self states were very, very young. And in order to be able to attune yourself to that self state, it was very different. So I thought if I had a relationship with Joe, that I had a relationship with the 7-year-old part, and that wasn't true. I had to reform my relationship with the 7-year-old part almost completely independently. All right. So then where I'm heading us to is that trauma is reenacted and repeated in disguised form. And a lot of what Bessel van der Kolk said maybe 30 years ago was that the body keeps the score, meaning that trauma is stored in the body. And even though the person is unable to remember sometimes what happened to them or the details of what happened to them, the body remembers it in some ways. And so the acting out is a form of almost a dedication to recalling what happened in disguised form. And so the person may not remember it, but the mind does in some ways. And so, for example, one of the clients that was having a lot of affairs would say that every time he had an affair, he would experience butterflies. And the butterflies to him meant a feeling inside his stomach that would come about. And the butterflies, it turns out, was the feeling he had when his father had sex with him incestuously. And he didn't remember that his father had sex with him, but the butterflies was the connection between the past and the present. So when he would act out, he would get butterflies, but when he had sex with his wife, he did not. And so it was the mind beginning to allow him to remember what happened to me why did it happen to me? And why did my father do this to me? And why did I like the connection but hate the incest? And so the only thing that connected him to that were the butterflies. And so when I was able to take the sexual addiction and begin to have him bring the feelings that he had when he was acting out into my office and experience the butterflies, he then could begin to get the cognition that went with the affect, and he could remember what happened to him with his father. And we did a lot of work around the incest and taking that which is unconscious and bringing it into consciousness. And as we did that, there was lots of pain in knowing, but lots of relief in beginning to finally get why his out of control behavior had some function and purpose. And so a lot of times in therapy, we're dependent upon the symptom in order to begin to know about the trauma. So the repetition compulsion is really an important component of working in psychotherapy. Now, what's the number one repetition compulsion for most people? It's finding a mate. What we do when we find a mate is we take the unfinished business from our family of origin and from the early relationships that are unfinished, and we reenact them in the choice of partner and then what we actively create. I mean, love with a partner is a verb. We're recreating something in that relationship. And either what we're creating is a solution to a lot of the early trauma, or it's a repetition of the early trauma in disguised form. And so this apparent compulsion to repeat these tragic scripts are unconscious efforts to create coherence. Now, this is the key element of what I want to say today, which is that our brains seem to be attempting to create connection, linkages, as Dan Siegel says, or coherence, where the past and the present can find some sort of connection. And so what good psychotherapy is about is putting the pieces of the puzzle of one's life together and developing coherence, so things that have never made any sense at all make perfect sense. And of course, if you think about sexual addiction, it is really an attempt to get clues, because what the person's doing makes no goddamn sense in a rational way, but makes perfect sense whenever you are able to develop coherence and be able to understand. So one of my clients who, for example, would go out with prostitutes and have prostitutes beat them and then go home to a wife and kids, that they didn't understand why that was absolutely essential and necessary until we were able to go back and walk through so much of the childhood, and his relationship with his mother was excruciatingly painful and necessary and distressing at the same time. And so when he could go back and pull in some of the missing pieces, in that case, I had to bring his father in. And his father would validate so many of the experiences of excruciating pain that went with his being abandoned by his own mother. And as he began to bring that which is unconscious into consciousness, he could see what it is he was doing. And his young parts were repeating that because they had the idea that loving was always associated with pain. And therefore, by ritualizing it into sadomasochistic kind of behavior, it was the solution. But when he understood that sadomasochism was actually a part of a post-traumatic stress and what he actually experienced in his childhood, then he didn't need to ritualize it into his sexual fantasy patterns. So these unintegrated past traumatic experiences actually happen, and they become plugged into your emotional system and needs to be repeated in disguised form. And the person is re-experiencing the terror and the fear that they once experienced as children, but in ritualized form. This time, I'm in control of it. It's not happening to me, it's happening by me. And the person is now in some control of that which was uncontrollable. So the pieces of the puzzle are dissociatively inaccessible, and the person is beginning to bring that which is unconscious into consciousness, and instead associating what really happened. And so the experience of therapy is putting the pieces of the puzzle together in a coherent way. And when they fit together tight as a puzzle, then the person is no longer unconscious but conscious, and no longer dissociating but reassociating. And that process is going to be exquisitely painful and necessary. Now, we repeat the dissociative process because it maintains the isolation of the elements of the experience, riddled with shame, terror, hatred, and helplessness, the affect that's embedded in the pain. And so the sexual addiction always is an attempt to tell our story. And what Chafetz says is, we repeat by virtue of the magic of the theft that steals the links between the elements of experience. God, I love that use of words. The virtue of the magic of the theft who steals the links between the elements of experience. I love when people can put in words that elegance. And that really says everything. So before you go into, a person becoming abstinent, and I have a client who, has been abstinent now for 6 months from their addiction. But I worry about the client because instead of just going into gross abstinence, they're not really attempting to understand the function of their symptom. And in many ways, until you can uncover the function of the symptom, going into abstinence is a little bit premature because you're not understanding that something has to substitute and take its place. And so as the person is abstinent from sexual addiction, their life is totally out of control with workaholism, with a variety of other ways of starting lots of different tasks but not finishing them, almost with a manic kind of reaction where all this energy is getting thwarted into alternative ways of releasing that have no coherence. And so I want with abstinence for the person to do the hard work of looking at the function of their symptom, how it came into being originally, and the function that it served for them developmentally before they're really able to go into a full abstinence. So when a person relapses, I look at that not as a failure of the therapy, but as a way of communicating that what we're doing is necessary but not sufficient. We need to go deeper, and we have to begin to look at the developmental experience of what happened to them growing up and how these dissociated elements are absolutely necessary to keep that from coming into consciousness. And why is that necessary in some ways? So dissociation basically disrupts the linking of the elements of experience that actually go together. And so what we're doing in plain old psychotherapy is we're beginning to provide those linkages, and we're understanding that acting out is an attempt to make sense of those disparate elements. Now, the key then in doing that is understanding that dissociation means that things have been put into different self states, and different self states hold affect, cognition. And so we're remembering the original Basque model, behavior, affect, sensation, and knowledge, BASK, Basque. And in the Basque model, there was behavior, affect, sensation, and knowledge. And now what we're saying is that in dissociation, there are different self states, and each of them contain behavior, affect, sensation, and knowledge, different than the other self states. And so we're reliant on the sexual addiction to access the self states that hold the affect, cognition, sensation, and knowledge of the trauma. And so when I'm dealing with an anorexic, I'm going to have to begin to access the self states that hold the anorexia. Now, the person who comes into my office is usually the host personality. And the host personality is Joe or Jane. And we're dealing with the psychotherapy with them. But when we're doing good work with them, we may not be doing good work with the self states. So learning to access those self states and bring them into the room are really necessary. So the innovations of ego states therapy or internal family systems therapy or Gestalt or any of the affect-based psychotherapies are really saying we have to bring into our 50-minute hour the self state that holds the whole network, and bring those parts of self in and work with those parts in some ways. I think the reason why internal family systems has caught on as a really innovative, powerful form of therapy is that it quickly accesses these self states and brings them into the 50-minute hour and allows you to work with the parts that are holding the trauma and the trauma reenactment and begin to work with those parts, then allows the person to alleviate the symptoms that they're bringing in some ways. The problem is that these psychotherapy modalities take a fair amount of training. Having worked with Dick Schwartz myself in internal family systems, what you realize is that it's not the technique itself, but it's the relationship that the therapist is capable of building with the client in this self state and being attuned yourself to the self state that becomes so important. Dick Schwartz calls that being in self. And he teaches the therapist how to be in self rather than being in parts. When I was working with Dick, what I realized is that I had a self state that was doing psychotherapy. I called that my psychologist self. And I was trained as a psychologist. I was trained to be a technician who could come in and use behavioral-based therapies in order to be able to do interventions that were evidence-based. And that part of me that was doing evidence-based psychotherapy, my psychologist self, was necessary but not sufficient. And that I also had a part of me who was more of a healer. And that part of me was not coming into the room. And so I had to integrate my psychologist self with my healing self. And as those parts became integrated, I became a much more competent psychotherapist. But I had realized that when you're not in self yourself and you're having a part do psychotherapy, the part that wants to fix the client, you're not really doing good psychotherapy at all. I hope I'm being clear, because it's a really difficult concept to get across. But teaching that therapist to be in self means that you're letting your parts that are trying to fix the client step back and letting you be present in the room as a healer and a person who's capable of love and caring. And being able to share that with the client allows the client to feel a secure base that then allows them to begin to heal themselves, which is the key of doing internal family systems therapy. All right, so this is the formal definition of dissociation, and it's a breakdown of a coherent sense of self, an integrated internal working models in a Bowlby sense. And the model for that really became incredibly useful was Mary Main's understanding of disorganized attachment. That with disorganized attachment, you have a parent who is dangerous or terrifying the child, and that the result of that was children are virtuosos in dissociation. The part of you that has to go to school is different than the part of you that comes home. The part of you that's with mama might be very different than the part of you that's with your friends. And so what has to happen to survive when you have disorganized attachment is these self states become more disparate and disconnected. And therefore, that which is unconscious becomes split into these different self states. So you can know things and not know them at the same time because a part of you knows it and a part of you doesn't know it. And therefore, a part of you may be acting out and doing something that feels disparate with your own value system. So, for example, let's say you steal from a store. Well, you may not have the value of stealing. You may find the stealing really just something that you can't tolerate, and dishonesty not being okay. And then another part of you becomes separate from that and finds that they steal. Well, the same thing would be true with having affairs. You may, in your value system, think having affairs and hurting the person you love in such a vital way is distasteful, and you would never want to be able to do that. And then there's another self state that feels like they can have affairs and be dishonest in that way. And when you have different self states that have different values, then the result of that is that you hate yourself because you can't even trust your own self, and you can't trust that you'll behave with any kind of sense of control. So you're out of control, and you don't trust yourself, and you don't feel safe with yourself. Well, what could be more painful than that? Because your idea of free will is destroyed because you believe that you have free will and you should be able to stop yourself from having affairs, but you can't stop yourself from having affairs because it isn't a matter of free will. It's embedded in a self system. So the devil made me do it. The devil in this case is the part that's doing the acting out that you have no control over. So what Dick Schwartz says is that parts of self hijack the eyes and hijack the mind and take control over the person. Or using ACT, acceptance and commitment therapy, what they say is that you're not driving the bus, that parts of you come in and take over driving the bus and you step aside. So in acceptance and commitment therapy, they ask, who's driving the bus? In internal family systems, what they say is that self needs to be driving the bus and your parts need to go to the back of the bus. So these parts that are out of control, sit back there at the end of the bus and, you do psychotherapy and you learn all this great stuff. And these parts are saying, when my time comes, I'm going to come back and take over again. And this fool doesn't realize that I can take over control anytime I want. So in this psychotherapy, what you're attempting to be able to do is not let those parts stay in the back of the bus, waiting for them to hijack, but instead bring the parts into the psychotherapy room and help them begin to integrate with the adult self. And so when Dick Schwartz has internal family system, it was actually quite profound because what he was saying is we have to do family therapy with you and your parts in the same way we do family therapy with you and your brothers and sisters, which is that when you have family therapy, the goal is to bring the different family members in and to start a conversation and have them begin to talk to one another and know what each other knows in order to be able to have them act as a family. When internally family systems, you're taking the parts from the back of the bus and you're bringing them in the room so that we can have a conversation. So the parts that are doing the sexual acting out, we want to know what they know, we want to feel what they feel, and we want to learn why they do that they do. And instead of trying to control them and shame them and finger wag them and say, I want to get rid of you, instead what we want to do is to integrate them and integrate what they know and they feel into consciousness. Because they're dissociative parts, they hold knowledge, sensations, and feelings. When you try to get rid of them, it's like cutting off your arm or cutting off your leg. There's a cost to it because they're part of your ability to be vital. Now, that's really an important concept, so let me just reiterate it. When you are an addict, you are numb. You are not vital. Your life does not have much joy. You are having anhedonia, an inability to experience joy and pleasure. And the cost of dissociation is anhedonia. And so their experience of a sunset, their experience of love, their experience of creativity has nowhere near the passion and the joy that a person who is not dissociated has. And so what I try to do is I try to put passion into a person's life. I open up the door for exuberance and the passion and exuberance of living and being alive. And that to me is the cure to addiction. The cost of addiction is where a person feels like they can't feel much joy except for from their addictive substance. So when the man says to me, I'd rather die than give up my pornography, I feel compassion. Because what a pathetic life that person must have, where the only joy he can get and the only escape from his own emptiness and boredom is pornography. And I don't want to take that pornography away. What I want to give him is the ability to feel the joy and pleasure and exuberance from life and love that then replaces it in some ways. I've got something 100 or 1,000 times better to offer him. So Dick Schwartz calls this, I'm a hope merchant. I love that term, a hope merchant. I'm a hope merchant. You have as your only source of joy pornography. I have something 1,000 times better than pornography to offer you. What is it that I have to offer? Which is being alive and being able to experience the joys and pleasures of life and of love. And when you are connected to another person, when you're caring about another person, when you have the capacity to love another person, it opens up tremendous joy in your life. And that's what we have to offer. Now that's secure attachment. So Mary Main's concept of earned secure attachment became critical in being able to cure sexual addiction, because earned secure attachment means that you have a secure base, that you can make connections with yourself and others, and that you've opened up a person's vitality to be able to really experience the joys of life and living. And they're kind of what you might call walking dead. Sexual addiction is a walking deadness. And it's not just about sex. So eating disorder is not just about food, and sex addiction is not about sex. And I'll tell you the truth, when they're having sex, it's probably not very sexual. It's about emotional release. It's about tension release. It's about escape from emptiness. But I doubt if it has much to do with sexuality at all. Just like, I had a client who had anorexia. And as we did our work around the anorexia and lifted it, the person went over to the house and they had a sandwich, and they came back to me and they said, wow, sandwiches are good. I never tasted a sandwich before. It's delicious. And I thought to myself, there it is. There it is. That when I taste a sandwich, it can be really delicious and I can enjoy it. But that person's experience of a sandwich was completely numb and empty. And when the therapy worked, it meant that they could taste the sandwich and it was delicious. And when you're treating sexual addiction, what it means is that I had my wife hold me. And when she held me, I felt connected. I felt passion. I felt desire. I felt like I was not so alone. And it was pure joy. And so I know that I have to replace the experience of pornography with that of connection. And it always seems like a paradox. What do you mean? The person loves their wife. So what they're experiencing when they're with their partner is probably not similar to what you're experiencing, because what they're experiencing is maybe a sense of not being alone. The man who said to me, I don't know if I've ever loved anybody. He was in a committed relationship and he was playing house with that person. He was doing what he thought he's supposed to do and did everything he could not to disappoint her. But in some ways it was like a living hell. And he just longed to be alone because there was so much pressure when he was with the other person of codependency. If I don't please her, she won't stay with me, because who would want to stay with someone as disgusting as me? And so being with that other person felt like pressure. And when he was away from her, there was relief, because it was the only time he didn't have to be pleasing that other person. And so I think you get it. What I'm trying to say is that just because they're in a partnership doesn't mean that they're a capacity for secure attachment. So you're always trying to seed the capacity for secure attachment, seed the capacity for love, and breaking down the defenses so that they can allow themselves to be loved. the only way to be able to do that is for them to have a connection with themselves. What's blocking their connection from themselves are dissociative barriers. What are those dissociative barriers? Usually they're amnesia and events that they are not allowing themselves to know or feel or remember because they were too scary at the time, and they're embedded in different self states. Okay, so I called this lecture Sexual Addiction, an Alternative Treatment Approach. And what I was trying to get at by that title was that if I look at the 10 books I have on sexual addiction, not one of them mentions, well, one of them does, mentions dissociation. But they don't say the things that we're saying today, which is the key aspect of working with the sexual addict, is working with the trauma and beginning to allow coherence and linkages of the dissociated elements. And by doing that, you have to work with different self states and integrate those self states into the whole. And that when you're able to do that, the sexual addiction remits itself, and the person's able to get the joy and pleasure of loving and sexuality in its real sense, just like with the eating disorder client. So many of the eating disorder clients that I treated 5 or 6 years ago, they've come back and they've told me that when they sit down at the table, there's no eating disorder at all. They don't count calories. They're not looking at their stomach. They're not weighing themselves. They're just enjoying the food. And if you take that analogy, or what you want to be able to have as a person who, when they get into bed with the person that they love, they're not thinking about their erections. They're not thinking about their orgasms. They're not thinking about performance. They're just feeling the connection and affection with another person, which is what sexuality obviously is about more than anything else, but which they have no frame of reference. Now, having disorganized attachment does leave you vulnerable to developing dissociation response with other traumas. So rarely can you just deal with the childhood trauma, because most of the clients that we see have 6 or 7 traumas that overlie their original trauma. And so the problem with doing post-traumatic stress work is that if you do a piece of post-traumatic stress work, usually there's another piece of trauma underneath it. And usually the trauma that the person brings in is not the trauma. So let's say, for example, the person was sexually abused, which is the big T trauma. And we think that if we do good trauma resolution work around the big T trauma, which is sexual abuse, that the person will then be able to reassociate and get a whole lot better. And they do. But the problem behind that is underneath each trauma is usually another trauma, and underneath that is another trauma. And what you find is that maybe the 7-year-old self state that experienced the incest, for example, is you're doing work with that part and they're getting better, but then the person's been raped or had a date rape in adulthood where they dissociated when they were with a partner, and when they woke back up, they realized they just had sex with a partner, but they were in a highly dissociative state, and it felt like rape even though it wasn't technically a rape. So there are usually traumas superimposed upon those earlier traumas, and dissociation leaves a person vulnerable to having all kinds of bad things happen, because you go away when you're with somebody. Let's say you have a partner who's really angry with you all the time, and you just, whenever they're angry with you, you numb out and you go away, and then you tolerate their anger with you. Don't put up your limits and your boundaries because you're in a highly dissociated state. So that relationship became a source of tremendous trauma. So the person is working through not one trauma, but multiple traumas that because your dissociation has left you vulnerable. Let's think of a good metaphor for that. The Vietnam War, if you have 100 people who have experienced the same trauma of being in the front lines of the war, maybe only 2 of them would develop post-traumatic stress. Why is that? What's unique about those 2? Well, they dissociate when they're in the front line and flash into an earlier traumatic experience that leaves them much more responsive to the PTSD of the war trauma. So what happens is that because you develop dissociation as a defense, it leaves you much more vulnerable to the war trauma and developing war trauma around the PTSD. And so that idea of this then is that not only do you have the original incest experience, but then you have the war trauma. So the women who are volunteering to go to Afghanistan, a lot of them were sexually abused as children. They dissociate and numb out, which makes them much more vulnerable to PTSD in Afghanistan. So as you deal with one, you have to begin to deal with the other, all bringing the dissociative experiences in some way. So I hope you get what I'm saying, is that the reason why this work is so complicated is that there are multiple levels that you're dealing with. And, we do time-limited work here. Our average client comes in for like 3 months. We see them 3 times a week. The only way to be able to afford that is to work in a partial hospitalization modality. And it allows us to have increased lengths of stay and allows us to do some of the deep work. But as we're layering it and doing a piece of work around the incest, on top of that we have to begin to deal with the multiple traumas that are sort of organized on top of that in a hierarchical kind of way. Okay, so as we're beginning to break down these traumatic experiences, what we discover is that the biggest block to disorganized attachment turning into earned secure attachment is loyalty to the family. Now, this is a really confusing term because loyalty to the family means that any information that's inconsistent is blocked out. So you say, my family loved me and I love them. And that's your conclusion. Any information that's inconsistent with that is dissociated out. And so therapists sometimes get a bad rap by saying, well, therapists are somehow making you feel anger at your family in a variety of ways, or they're teaching you to hate your mother kind of thing. And I never sort of fall into that trap, because people can feel 2 ways at the same time. They can feel love for somebody and anger towards somebody at the same time. And so what we're trying to be able to do is looking at anger at what so-and-so did to you, but you can still love them at the same time. And helping people understand that binary kind of concept is really important, because they want to hold on to, I love my mother and my mother loved me, but she did these horrible things to me along the way that made me fear her and terrorize her in some ways. So that's what we try to do within the group setting, is you get to talk about what happened to you and still hold on to your I love mother and mother love me kind of thing. So this thing about binary kind of thinking, that either I love somebody or hate somebody, is not really reasonable. And that part of the trauma bond is thinking in that binary kind of way. So you can continue having the belief that you had a good childhood and that you had many elements of a loving family and you were not necessarily neglected or abused, but bad things happened to you along the way. And you get to acknowledge those bad things and be angry at the person for what they did to you and still love them at the same time. And you get that a lot, for example, with mothers who didn't have mothers themselves. And so one of the things that's so common in the group that I deal with is we oftentimes will bring the mother in, and the mother will tell you that she did not have a mother for themselves, that their mother was absent, that their mother died, that there wasn't a mother figure in their life. And so then they become a mother themselves, but they don't really know how to mother. And so they go through the motions in a dissociative way of mothering, of taking care of the child, but they have limits in their capacity to love the child. And the child accurately senses that. I did a training with Patricia Crittenden, and she showed these videotapes. of mothers who were disorganized with their children and didn't seem to have the capacity to show love. And they did a training with the mothers, and they taught them how to be good enough mothers. And so what would happen is in the videotape is the mother would be smiling and rocking and holding the child. And then she showed this clip where the mother looked away and for a moment was disorganized and disconnected and dissociated. And the infant, they showed a picture of the infant, and the infant was totally disorganized, was salivating and was rocking. And the child accurately picked up, even though the mother was acting like she was loving, when the mother was dissociated, disorganized in some ways. And I'll never forget that because I realized that children are incredibly attuned. They have Bluetooth, and they can pick up when the mother is acting like she loves but was not really capable of loving because they had their own deprivation in some ways. So in these studies that are trying to teach mothers good enough mothering, it's probably necessary but not sufficient, because what's necessary in working with that mother is to work with her own dissociated state and help them remember and feel and have the capacity for real passion and deal with their own depersonalized state rather than teaching them how to be a good enough mother. And so children pick that up accurately in some ways. So in our therapy, so often we've had mothers who were incapable of genuinely loving their children, but acted like they loved their children. And the kids picked that up accurately, and there was some deficit in their capacity to love in some ways. And so they come in and they know that something was missing, but they feel frustrated because their mother, they bought them Christmas presents, they had meals on the table, they had no right to even complain, but they sensed that there was something missing in some ways. And what the child then grows up to believe is they're defective, they're bad, there's something wrong with them, and they don't really know why. So the loyalty to the family becomes something that we have to begin to look at and take off the rose-colored glasses. And so oftentimes by bringing the mother in, we can begin to deal with her own traumas and help the mother begin to acknowledge some of her own deficits and begin to repair the damage that has been done in a real-life kind of way that allows for a secure attachment to begin to formulate. So often what we long for are parents who will acknowledge their own deficits and own up to them and be able to say, "Oh, sorry that I wasn't there for you in the way that I really needed to be," and the child to be able to acknowledge the result of that, which was they felt like they were defective children rather than realizing that they were neglected in varieties of ways. Selma Freiberg long ago said that there are parents who say explicitly, in effect, "I remember what it was like." And what happens is that by beginning to remember and talk about and feel your trauma, you don't then repeat it on to the next generation. The repetition compulsion is that anything that's unfinished in your life, your children have to finish for you. And so when a person does the hard work of working on their own trauma, the person who benefits the most is their own children. And otherwise, the children are going to repeat it in some ways. Now, sexual addiction then is oftentimes a form of blind repetition. A person will come in and they'll say, "I don't remember any trauma in my life." And then what we'll find is that the mother was raped, and the mother never dealt with her own rape, and so the child is dealing with the mother's rape in disguised form. Or the father was having chronic affairs on the mother, and the child sensed it in some ways, but it never came out. And so the child is repeating what the father did in disguised form. And so what we want to remember is that sometimes it's intergenerational trauma that's being acted out. And so when we're looking for what happened to the person, sometimes it's what didn't happen to the person that they needed, or something they sensed that was happening in some ways. So I am a family systems therapist. And when a person is reenacting and repeating, I want to bring the mother or the father, the brother and the sister in And I want to begin to understand systemically what was going on that the person sensed in some way and was repeating or reenacting. This is a quote from one of my clients, and it's hard to listen to, so bear with me. She said, to think about my father raping me and his sweat dripping off my small body turns me into stone. That's dissociation. While all this happened, I was stone. I was dead. I was gone. Yes, gone far beyond imagination, far into a world where I walked around like a ghost. Dissociation. I was in this world where life passed me by. I only hoped to come out and come out alive. But it seems I am alive, yet I did come out alive. But my question is, am I alive? Am I really living? I feel like I'm not. Now, as an attuned therapist, I was videotaping this session. I wrote this down, and I asked myself, what is the client really trying to say to me? Which is, they're walking dead. No wonder they need addiction. But the truth is, I live on other people. I live depending on other people to see me to the end. That's love addiction. Where does that leave me? They would cut on themselves, and it made me feel real. It helped me fulfill the need for pain. Because without pain, I would think I was real. Now, just listen to those words. God, they say so much. Sexual addiction is a form of self-cutting. It's a way of causing themselves pain. Pain is necessary for pleasure. Pain is necessary to feel alive in some ways. So when the client says, if I give up pornography, I feel like I'm going to die, it's just another form of self-cutting. And if you don't understand why a person cuts themselves, you don't understand why a person is anorexic. And if you don't understand why a person's anorexic, you don't understand why a person's a sex addict. They're all interrelated to one another. But those fields diverged and they became separate in some ways. And I think that behind each of the three of them is the dissociation. Now, when she wrote this out, it was the beginning of the end of her self-cutting, because she was bringing into consciousness that which was unconscious. She was able to talk about it and feel about it with me in a safe way. Now, it turns out that trauma work has taught me and other people that the reliving of the trauma may not be the critical element of getting better. It's the critical element of getting better is the rumination about the trauma. And so you're left feeling, I'm bad, I'm defective, and those are remnants of what happened to you. But you're left with just the belief systems that are embedded in your mind. And so you're beginning to deal with the ruminations. I feel like I'm defective and I'm bad, and shame. And by neutralizing that shame, the person is becoming alive. But to neutralize their shame, they have to remember what happened to them and begin to have some re-experiencing of what it was like to have the trauma experience. So this is what's happening in this piece right here is she's re-experiencing what happened to her, she's feeling it, and she's becoming alive again. And so often what happens in understanding dissociation is the person becomes real. You're taking the false self and you're helping them become real. So in effect, what I'm saying to you is, I don't think you can deal with sexual addiction in just 12-step work, in just abstinence work, in just relapse prevention work. I think you have to go deep, do a deep dive, and help the person become alive. One of the clients with eating disorder said to me, I came in here to deal with my eating disorder, but I realized that everything in my life has to change if I'm going to give up my eating disorder. And I thought, that is the most brilliant statement I've ever heard, because she has built and accommodated a whole life around her eating disorder, a numbness. And if you're going to become present in your own body, if you're going to become alive, if you're going to become a participant in your own life, you have to begin to reassociate and be in your body and not be so numb. You have to feel your feelings and you have to feel your pain. If you're afraid of feeling pain, you can't feel joy. And if you don't want to get into a loving relationship because you're liable to get abandoned, it means you're avoiding the pain, which means you're going to avoid the pleasure. So you have to have the courage to suffer and to feel pain and suffering in order to feel joy. And so it has to be a conscious decision on your part that you are going to be present in your own life and experience what you're experiencing in order to become real. It's that velveteen rabbit kind of thing where you become real and become alive and become a present person in your own life that's necessary. So everything in your life has to change if you're going to give up sexual addiction. You have to become real. You have to become present. You have to reassociate. You can't be numb. You have to be a participant in your own life. And you have to have tremendous courage because you're going to have to go through the pain to get to the other side of the tunnel. And you're going to have to remember and feel all those things that you've unconsciously pushed away. So David Kaloff said this back in 1991, and I'm saying it again. Self-injury is the container for unmetabolized traumatic stress. Self-injury is a functional and always attempt to protect the client, and it expresses the dynamics that are translogical. Hurting releases the pain. But because behavior is dissociated from sensation, affect, and knowledge, it will be unclear. Now, hopefully that strange quote will begin to make sense to you now, because what he's really saying is that when there is trauma, there is dissociation, and the person's life becomes dedicated to reliving that trauma in disguised form through self-injury. So whether it's cutting on yourself, whether it's eating disorder and being anorexic, which is I don't want to have needs and I don't want to feel anything, and hunger is a need, or whether it's sexual addiction, which is I don't want to allow myself to get close to another human being because they're going to just hurt me and they're going to abandon me and they're going to find out that I'm a defective human being and no one's ever going to want to stay with a defective human being. So I need to protect myself from that. Self-addiction is functional. Sex addiction is necessary until the person is able to realize that their beliefs that they're dysfunctional and defective and shame-bound are released in some ways. And they remember that their symptom is a form of remembering in disguised form. So once they actually do remember, they don't need to have the symptom anymore. Isn't this a fascinating quote? All right. So we're understanding then if sexual addiction is a form of self-injury, it is going to have many functions. One of them is it is rage. It's rage acted out in some ways. When you are cutting on yourself, it is violent. It is, hurting someone else and hurting yourself are the same act. They're acts of rage in some ways. It also grounds you. When you're numb, you'll do anything to feel present. So when the person says, I need to have my pain in order to know I'm alive, it's grounding. Don't take my pornography away from me. It's because it's the only time I know I'm alive. It's a mood alter. I feel dysphoric all the time. I feel numb all the time. And the only thing that allows me to feel a little bit of relief from that is my addiction. It's a way of remembering something bad happened to me. I don't know what it is, but I know something bad happened to me. And you're communicating to the outside world. When I cut on myself, people know that on the outside doesn't match what's on the inside. On the outside, I look happy, but on the inside, I feel empty. I feel hollow. I feel defective. I'm tired of feeling so empty and hollow. This is the only way I can let people know in some ways. I can show you in some way. So parts of self are screaming, help, help, help. I'm alone in here. I've been abandoned, and I need to have connection. And the only way they can communicate is with the symptom. So by turning to these self states and communicating with them and beginning to have a conversation with them, you're entering them into the system, and they don't feel so alone. So Dick Schwartz says it's not your connection with others, it's your connection with self. And it's called self-healing because you're allowing the person to reparent these injured parts of self and bring them into the self system and give them love, nurturing, and connection that they've not been able to find. So what makes trauma so traumatic is how alone you feel. And by beginning to create self-leadership, what you're able to do is help these parts not feel so alone and to recognize they need other people and they need connection with self and others in a variety of ways. Now, Michael Lewis, in his book on rage and anger, separates anger from rage. And I always found this really useful as an element of dealing with sexual addiction, because I think sexual addiction is always about rage. And you have to know what rage is to know what I mean. Anger, you feel justified. Someone's hurting you. Rage is you feel powerless. Injury is recognized. This person hurt me. Rage is your loyalty to your family. Anger is conscious, whereas rage is basically unconscious. Anger is resolvable. Shame that comes from rage is unresolvable. Anger is displaced. I hurt myself. Rage is somehow diffused. So what we're doing then is we're ritualizing rage. So we have a 9, 10-year-old and they turn on to pornography. Not all people who turn to pornography become addicted to it. Some people just are able to use that as a rehearsal and find themselves capable of loving others. So it's not like I'm against all porn. I think pornography has had its positives in the sense of people who have had this emptiness and not really understanding their sensuality and sexuality. It could be useful. But for the people who become addicted to pornography, it's because they also have an intimacy disorder. They're also afraid of connecting to others. It's because they've had disorganized attachment. And so there's a self state that just insulates themselves. And so they use pornography as a way of withdrawing. And so they end up, when they're feeling scared, lonely, angry, sad, they use pornography and it becomes a way of dealing with all their emotions and all their affect. And it becomes compulsive. So these self states then have their own life. This is one of the clients who was about 16 years old, and she was having anorexia. And I basically accessed a persecutory part of self. And this is what she said. I'm the cruelest part of Judy. I tell her awful things all day. I force her to wear a mask, or nobody would like her for who she is. I make her feel like everyone's watching and judging her and thinking what a mighty dumb bitch she is. I compare herself to everyone, and she always comes out short. And so on down the line. I won't read the rest to you, but I wanted to illustrate this because when I start going inside, what I find is that the ruminations of these persecutory parts of self are almost constant in the mind of the addict. And so when I underestimate the level of rumination that they do, I underestimate the power of escaping from that through their addictive behaviors. So only when I begin to go in there, it's these ruminations that are the key to dealing with trauma. And so I think what we've gained in working in the trauma field now for some 30 years are a lot of what we're doing are dealing with these, what we call stuck points in the cognitive reprocessing therapy. And these stuck points are the ruminations that the person has as a result of the trauma that keep them ever from working through it in some ways. So a lot of what we're doing are dealing with these shame-bound ruminations. And these are the result of not knowing what actually really happened to you, the dissociative barriers. Now, I want to come back a little bit to sex addiction, because what Chafetz says is that the same thing's true with sexual addiction. And the person is having sex, but they're not really present. I'm seeing this epidemic of girls coming in who are hooking up on the internet at 3 o'clock in the morning with strangers. And it scares me half to death because of the terrible things that could happen. But it never occurs to them because the self state that's present is completely in a dissociated state. And they don't realize how dangerous and scary what they're doing. And it's not that they pick people who are pretty or desirable in that way. They just sort of are enacting something unconsciously. And so as you begin to talk with them, they'll say, when I'm having sex, sometimes my partner complains that I seem to be not present. But I honestly don't know what he's talking about because I have no memory for it. I don't know how it actually happens, but there's a kind of energy I feel in my body. And it's as if I'm watching the scene rather than in charge of what I'm doing. This is from Chafetz's book, a quote. He says, I'm really frightened because I can see what I'm doing. I know that I shouldn't, but it doesn't seem to matter. I still do it. So somehow fear seems to element as well as rage. Another person says, I'd rather be knitting than having sex. And while I'm doing it with him, I'm a million miles away, but he never seems to notice. Or pornography. I get in front of the screen of my computer and the rest of the world disappears. Hours go by. It's incredibly exciting. I'm also terrified the whole time, on and off. Now listen to their words. What they're saying is they're in a dissociated state. Anger and fear seems to be the emotion that they're feeling. They're completely numb, but it's not sexual at all. And it's not sensual at all. Sexuality and sensuality seems to be removed from sex in the dissociated state. So Chafetz says sexual addiction is not really about sex. And that's the same with eating disorder. It's not really about food. It's not that sex is irrelevant. It's that sex is just a stage which the underlying concerns are being played out. These concerns usually involve intense emotions like shame, terror, helplessness, rage, fear. These affect scripts are related to power and control and the loss thereof. So states of rage and powerlessness are present in the scripts. Okay, there it is in a nutshell. Client has little interest in sex, nor does she have any apparent interest in orgasm. They have little sense of connection to their own body. So what Chafetz says, and I think he's right, is sensuality was not an openly sought dimension of the experiential repertoire, but she has most of it, all the states filled with tension and a need to take action in a sexual manner. Sexual action hid painful feelings of shame and rage and terror. Okay, now let's take this. Sensuality and sexuality are no longer one. When they did the work with disorganized attachment, they would, in the studies of adolescents who had disorganized attachment or even avoidant attachment, what the girls said was, when I'm with a boy, I don't seem to feel anything. I feel numb. I have sex, but I don't see what people say is so pleasurable about it. I don't seem to get much out of it. I have sex because I'm supposed to, out of obligation, but I don't feel much pleasure or joy. So it's as if when someone's touching them, they don't feel sensual. The partner, whenever someone touches your face or your lips or your ears, your whole body gets on fire, particularly if you love the person and they love you. There's a sensuality. But sexuality that's disconnected from sensuality is what sexual addiction is about. And looking at the screen and conditioning your mind to turn on to the visual rather than to touch overloads those circuits with the visual and underloads your circuit with sensuality. So if you've never been picked up as a child, you've never been rocked, if you've never been touched, those circuitries towards the somatic and towards the haptic sense are understimulated, and what's overstimulated is the visual. So what we're doing is with pornography is conditioning a whole population of people that overstimulate themselves through the visual and understimulate themselves through the sensual. Now, what's the cure of that? I'll tell you an interesting thing is that when I was first being trained, I was being trained by Masters and Johnson. And what I was being trained in was in sensate focus. And in sensate focus, you would say to the person, I want you to go home and I want you to touch your partner, pressing breasts and genitals off limits. And I want you to have a sensual experience as opposed to a sexual experience. I want you to notice what you're feeling when you touch their face. I want you to notice what you're feeling. It was a mindfulness exercise. You touch the hair, what do you feel? And it was beginning to wire in the haptic sensual sense for people who were completely numb and to reassociate that which had been dissociated out. And we found that we could repair that system through sensate focus for most of the people we work with, and that they would leave and they would taste the food, they would feel the feelings, they would begin to love being next to the other person and cuddled with them as opposed to just having orgasm. And there has to be some component of repair of that system with a sexual addict, because as soon as you get them under control of the sexual addiction, what happens? They become hyposexual. They become numb. When they're with their partner, they feel nothing. And so sexual compulsion is always with sexual inhibition. And what we don't realize is an intimacy disorder is that it's two sides of the same coin. So when a person has an intimacy disorder, they're not going to suddenly get close to their partner and feel affection, because what happens is that sensuality, that haptic sense, has not been wired in. So we have to do a lot of work with sensate focus and sex therapy to begin to wire in the sensual. I have this whole group of people who are coming in who were, they started pornography between the ages of 7 and 12, and now they're just getting married. And when they're getting married, whenever they're touching their partner, they feel numb. And they don't get turned on by their partner. They have to create pornography in their mind in order to get turned on by their partner. And it really is, it's another form of re-victimization, because they can't really fully love their partner because they have to create images of other people in order to get turned on with their partner. And it's really unfair. And the partner feels unloved and uncared for, and they think it's about them when it's really about the fact that they've been hardwired in to the visual rather than the haptic sense in some ways. So as complicated as what I'm saying today is, there probably is necessarily a component of marital and sexual therapy that has to be overlaid with treating the sexual addiction. I don't know. I think 12-step groups are really good for getting under control, but by looking at it as something as simple as abstinence, we're not really recognizing the depth of what sexual addiction is really about, which is about an intimacy disorder. It's about numbness. It's about insecure attachment. And you're sentencing a person to a life of aloneness, because not now they don't have their sexual addiction, but they also don't have connection with other people. And what you're taking something away, you have to replace it with something much better. And it feels a little bit cruel to practice sobriety without teaching the person how to be able to have a real loving relationship with another person. What we're doing is we're reassociating, we're making linkages, we're beginning to take the past and put it in the present. And so the way I do therapy, I call it developmentally based psychotherapy. Because developmentally, I want the person to have a coherent narrative. I want them to be able to have a cohesive sense of who they are. And I want them to get out of their anhedonia and have a spiritual, value-based life. And so I oftentimes will do things like, what is your life about? What do you want to do while you're alive? What's important? I use acceptance and commitment therapy to do a lot of work around developing values, because I want the person to have a sense of who they are. And so in that case, what we have to do is seed the development of the real self. We have to help them become an adult. Most sex addicts have never grown up. They're living a perpetual adolescence. And what's involved with growing up is having a cohesive sense of self. How do you have a cohesive sense of self if you have amnesia for all these developmental experiences? So I have them do a timeline, and the timeline includes the events that have occurred in their life and the emotions and the feelings. And so I want them to tell their story, but I want their story to be a coherent one where 2 and 2 equals 4. And when you ask a person why they like being whipped, and why they like pain, and why they have to be scared, and why they have to have sex, with clothes that are of a certain nature, or have their partner dress up in a certain way, they don't have any idea of where that came from or how the origins of it. So I'm an ideologically based therapist. I want a person to know their story and know what happened to them, and the input to be able to understand the output. By understanding the input, we break the trauma bond that the past has control over the present. Because everything makes sense for a person. 2 and 2 always has to equal 4 when you break down the dissociative barriers. And so if they're enacting painful or humiliating experiences, it's directly a result of post-traumatic stresses where the way they survived was by allowing pain to become pleasure. What does that mean? How does pain become pleasure? Well, you remember the time when somebody was beating the shit out of you, and the only way you could deal with it was by not hurting, not feeling the pain. Your body allowed you to numb out, and that therefore you could laugh at them and say, "Hit me even harder because I don't really care." I had one guy who came in. He said, "Father would always say to me, 'Quit limping, be a man.'" And I was always in this pain, but nobody could find the source of that pain. Finally, when I was like 16, the doctor realized that I had something in there that needed surgery. And I remember that I could look at my dad and I would say, "Fuck you," that I really do have something wrong with me. And I got tremendous pleasure in the pain of being able to, to have the surgery, because I realized that I was finally, I was able to get back at my dad. So Starr used to say that he's converting the pain into pleasure because there's that vengeance. See, I told you so. I really was in pain at the time. And sexuality is a way of ritualizing that, which is pleasure becomes pain, pain becomes pleasure. And I need to have the ritualization as a memory of what happened to me, since I'm not able to keep it in my conscious mind. That person had a paraphilia, which was quite significant. And in that paraphilia, it was enacting the pain into pleasure. And in order to give up that paraphilia, we had to have him begin to do this post-traumatic work. Now, I want to say something specific about pornography, because I'm having people who are coming in and they're edging. For people who don't know what that means, they're going 3 to 4 hours into pornography, and they're going from 1 o'clock in the morning to 3 o'clock in the morning and losing track of time and then missing sleep. A lot of them are bipolar, and they're undiagnosed bipolarity. And we're seeing a very high incidence of bipolarity within the sexual addiction population. If you've never heard of that term before, they don't have bipolar disorder, but they have states of mania and states of depression. And the mania is like a dissociative trance that they're in, where they're out of control, and they're going into the internet is a form of hypomania. And you ought to read up on bipolarity, because it's much more common in the population, estimated to be in the 40% range in the population. And Lamictal is a particularly good drug for treating it. Anyway, for this dissociative trance, we are using Lamictal a lot, and it does seem to be really helpful for people. The unconscious finger movements are sort of intense erotic stimulation, and the addict self, the part of self that takes over when they turn on the pornography. So when you turn the computer on, it triggers the addict self to come out, and that part takes control. And so you're trying to use behavior therapy, but you're working with the wrong part, and that part that's using the addiction has great difficulty with sobriety because the addictive part takes over. And it's quite a serious problem. I just sort of give the top 10 sexual problems of using porn, which is it interferes with real intimacy with a partner. It has difficulty establishing a real relationship. You get into risky behaviors in a variety of ways, and so on. All right, I see I'm sort of running out of time. Let me just remind you that part of dissociation is also depersonalization, derealization. These are aspects of dissociation. And you don't feel like you're human. You feel like you're disconnected in some ways. And sometimes you feel like you're in a different world. Particularly some of the bipolar clients that we're seeing just feel like they're not in the same world as other people. And beginning to have some part of therapy is having somebody who finally gets them, and you can bring them into the lamb of the live. So, this addictive personality is having this big emptiness inside of you, a hollowness that you're trying to fill. And helping the person become human is really the key element of this. And by breaking down the dissociative barriers, they begin to taste the food, they begin to feel their feelings, they begin to feel alive and virtual again in a variety of ways. So let's see if I can just sort of conclude something what I've been trying to say today is that the alternative treatment model that I'm getting to is to not just deal with the symptom, but deal with the problem that's underneath the symptom. Not just deal with the trauma and do trauma resolution, but to understand that what you're really dealing with is helping the person who has a false self become real and see the development of the real self. And in doing that, the person needs to reparent themselves and connect with those disowned parts of self in a psychodynamic kind of way and begin to heal the self. And to do that, it takes allowing themselves to do a cohesive narrative of remembering these pieces of the life and making linkages and to feel their feelings. And temporarily, they may feel angry at the people who hurt them. But ultimately, what we're trying to do is have them reconnect to themselves and reconnect to the people in their lives. So I always do a systemic part where I'm doing family therapy, and I'm also dealing with couples therapy and sex therapy, because I want them to, once they get back in their own bodies and begin to feel, also be able to feel connections to the people in their lives, and have the people be able to make amends for the way that they've been hurt in a variety of ways. Let's take some questions.
Great, Mark. Let me start with this one. How does trauma bonding and attachment styles interact?
Yeah, I mean, I think that attachment styles are a direct result of early bonding. And, whether you're avoidantly attached or, most people have a combination of insecure attachment and avoidant attachment, the AC pattern. And when that becomes extreme, you're going to get disorganized attachment. When you get disorganized attachment, you're going to get dissociation. So one directly relates to the other.
Whether I use IFS or refer to it as different ego states, would you say that sexual compulsion is actually sexual repulsion repetition? And that's why sex offenders continue to reoffend?
Exactly. When I was working with people who offended on a regular basis, 90 to 95% of them have been sexually abused. Some of them remembered it, some of them hadn't. And there were ego states that were enacting that in some ways. And the field hadn't recognized the role of dissociation or even of trauma in dealing with that. And it was punish them, throw them away, put them in jail. But when you had adolescent offenders who were 12, 13, 14 years old who were molesting, suddenly we realized that we had to deal with their trauma and their enactment of that trauma. People who are acting out are always repetition compulsion. And by understanding that, it gives us a whole new lens in being able to treat people who are offenders.
Mark, could you comment on another less discussed form of trauma referred to as false empowerment, the building up of a child to believe they have more power than they deserve or should have? It's more passive trauma per se, but it puts children in a role that's developmentally inappropriate. False empowerment of this nature leads to entitlement, grandiosity, narcissism. I work with a lot of men who had this in their childhoods.
Yeah, the question is such a good one, which is, I did not talk about personality and how personality disorder fits into this, but you can just see the interaction. We're talking about people in the borderline narcissistic antisocial range. And the trouble with personality disorder is it sentences you to a certain disposition. And we see those as a result of disorganized attachment. So the personality begins to change as the person's real self becomes alive in some ways. So when they present themselves, they're going to look in the narcissistic range. If you think about bipolarity, one of the primary characteristics of bipolarity is a person has a grandiose sense of self. They're the only one in the world, and they feel invincible. And that aspect of bipolarity is almost always present in sex addicts. Bipolarity is treatable, and so is that grandiose personality. And it's not a personality disorder, it's the result of disorganized attachment. Well, thank you all, and appreciate you sitting through the 2 hours. And if you have questions, you can get in touch with me directly on my website. Thank you. Bye-bye.